Okay, everybody, we're going to go ahead and get started. Good afternoon. How is everybody? I just wanted to thank you all for being here because we know we are competing with the National Grand Rounds. And so just so you know, this is not the National Grand Rounds, and this is our topic, just to make sure you're in the right place. But we're super excited that you're here because we have something to share with you that we're all very passionate about. I've been working with all of my team for several years on this, and we think it works, and hopefully you'll learn something from this and can bring this home to your own respective institutions. So my name's Lynn Roppolo, and I'm on behalf of our group, I just want to welcome you and thank you, and also thank the Behavioral and Psychological Interest Group for endorsing this presentation. So here are our disclosures. So we have a problem, and this is a problem that we all who work in the emergency department know exists. I just want to ask you a question real quick. How many of you have been physically assaulted by a patient in the emergency department, right? Okay, I was physically assaulted, right? And I know many of you have probably seen many people physically assaulted. Before I begin, I just want to start by saying what we're going to present to you, I think, is practice changing, and it's changed my practice. I've had zero physical assault on anybody in the emergency department since I've been practicing the way that we're going to be talking about today. And so hopefully we can make an impact and share some of this with you. So as we know, I mean, it's very prevalent. 80% of violent injuries in the healthcare environment are from patients. And this was a survey by ASAP. 47% of ED physicians report that they have been physically assaulted in the ED. This is by patients. Now, we think that all of these are preventable, and I hope that you'll agree. So what if we were able to improve our ability to manage agitated patients? Because if you think about it, people who physically assault healthcare professionals aren't calm and collected and cool like all of you here in the audience. They're agitated. And so if we could kind of change this scenario, and this scenario is something, how many of you have seen this scenario in your emergency departments, right? This is something we see. When I was a resident, we were trained significant agitation, forceful restraint, and medication, and that was it. But so this we're all very familiar with, but this doesn't have to happen. Most physical assaults occur during this containment process that we do in the emergency department that we're all trained to do. So there is a much better way. Could you imagine that we change that scenario that we're all familiar with to something like this? It's a lot more compassionate, that provides better medical care, that is safer for all health care professionals. So our objectives today are to talk about how we can prevent workplace violence by reducing the physical assaults from these agitated patients on healthcare professionals. Okay, so here it's a balance, right? Agitation and calmness, and people are agitated for a variety of reasons, but this approach called BETA, which stands for the Best Practices in Evaluation and Treatment of Agitation, which was published in the Western Journal of Emergency Medicine in 2012. It's a series of many articles that cover all of the different steps, and we're going to summarize it for you and make it easier. These are, to the best they can be, evidence-based and guideline-based from experts in the field, emergency medicine physicians, and psychiatrists. So here are the 5 steps that we broke it down to make it easy, and this is not a detailed review of all of this information. It's really just an overview, and we broke it into 5 simple steps, so hopefully you can bring this back to your people in your emergency departments to prevent physical assaults and decrease workplace violence is kind of our approach. But we have some references for you to review if you want more information. Our contact information is at the end, and if you want to contact us, any of us we're so passionate about this that we're happy to lecture to your group if you're interested, or give you the tools so you can do that at your own institutions. So I'm just going to talk to you briefly about risk assessment and safety. So this is very important. Before I knew about BETA, I would get an agitated patient and I would literally go the opposite way. And I'd think, okay, the nurses are going to handle this for me. But that was the wrong way, because by avoiding the problem actually would become worse, and people would get physically assaulted. And then when I would come on board, it would be much later and too late in the game, and There's so many things that could have been prevented. So big point is that safety is always first. When you see an agitated patient, you want to keep your distance, you want to make your assessment, you want to call for help, you want to call resources. If you have police who are trained to de-escalate and can help you, who are trained to physically restrain patients, if that happens, which is a last resort, there's so many steps that we're going to go through that should take place before that even happens. So your rapid assessment of their agitated state could be by a variety of means, and this is just one example. This is the Behavioral Activity Rating Scale, or the BARS, and by having some kind of system to communicate with your colleagues makes it easier. When you say, oh, I have a guy who's got a BARS of 7, instead of going through all the descriptives and trying to explain like how severely agitated this person is. So severe is somebody that's physically like combative or on the verge of just hitting somebody or injuring themselves. Mild is somebody who just has increased psychomotor movement. They're very verbose, but you can de-escalate them. And then moderate is in between, and people fluctuate levels. Even though you brought them down to a mild state, they could easily escalate to a severe state. So this is basically part of your risk assessment. And then hopefully everybody here is at a calm state. I'm probably at bars of 5 right now, but all of you guys look like you're at bars at 4. So I want to emphasize, though, that we kind of take this for granted, but a verbal assault is a huge risk for battery. I mean, the next step is they're yelling at you. The next thing they're going to be is, potentially hitting you. So that should be something that you should assess in patients and say, okay, this person's at high risk. What do I need to do? How can I bring them down? Do I need to call the police, et cetera? And then one other thing that we need to mention, especially in this setting of somebody that you might potentially have to physically restrain and force medications on them, it's just their capacity. And we're not going to go into a detailed review of what this is, but you guys have all heard this before, but just something we need to be mentioning. So as we know, and we've seen this a lot in the emergency department, people with capacity have or can make bad decisions. And we see this all the time, and these are our patients frequently that come in with an agitated state. So like anybody else in the emergency department, what we initially do is we look for life threats, because agitated patients aren't just people who are intoxicated or who have underlying psychiatric issues. They could have some life threats, and so we'd be remiss if we didn't mention. These are things that you're very familiar with: extremes in age, trauma, neurologic deficit, delirium. So just make sure you're assessing for that, because those are people that need more rapid attention, that you're not going to be taking all this time to try to de-escalate them, because they're never going to get down to that state. You need to kind of take control, because they could potentially have a significant brain injury or some other life-threatening issue. But what you really want to do when you initially approach these patients is some of the, your risk assessment, but put them in a place in your emergency department where it's safe to take care of them, where you have room. There's not a bunch of stuff in there that could, they can take and throw at you, in Parkland. So I just retired. I like saying that. From UT Southwestern, I worked at Parkland in the emergency department, the busiest ED in the entire country, over 220,000 patient visits annually. And so we would bring our patients to this area, critical care area, where we had room, we could take care of them most of the time. And then, we would call for help, we'd call the police, we'd call for extra help. And then the big thing is just preventing injury to the people around you, preventing injury to your patient. So now Dr. M is going to talk to you about de-escalation, which I think is the most powerful tool in managing agitated patients.
Thank you. Great. So the second step in agitation management is verbal de-escalation. And as we know, we face many challenges when we're trying to de-escalate patients in the emergency department setting, and that includes patient factors, including patients' perception of threat, their history of trauma that they're bringing into the ED, and also their negative experience with the healthcare setting as well as law enforcement. And on top of that, our performance factors really play into it as well. That includes our knowledge and our skill sets and our comfort level with managing an agitated patient, as well as some of the competing priorities that we have to work with when we are managing multiple patients at the same time. And our behavioral factors, that includes our own trauma history that we bring to our work setting, in addition to our judgment and our biases that could shape how we feel comfortable taking care of the patient who's presenting to the emergency department with agitation. And also systems factors that include ED crowding and also staffing challenges and the lack of training that is provided to ED staff. And lastly, team factors that can lead to lack of coordination and also lack of standardized approach. And unfortunately, these challenges can make us prone to providing inequitable care in the ED. That could result in disparities in agitation management, as well as who we end up restraining in the emergency department setting. So this is a study from 2021 of looking at all ED encounters with involuntary commitment, so patients who are waiting for a psychiatric assessment or waiting for a placement. And this was conducted in New England within an 11-hospital health system where I practice. And they looked at 2-year period and seeing who got restrained and who did not get restrained out of this patient population. These factors are associated with restraint use, and that included male sex, African American race, Hispanic ethnicity, Medicaid insurance, and also prior diagnosis of bipolar disorder and psychotic disorder that were documented in the chart. And we unfortunately see similar findings in other studies, including seeing racial and ethnic disparities in physical restraint use in a pediatric emergency department setting. So these are 10 domains of de-escalation from the Beta guidelines. So first, respect your patient's personal space. So having too many patients in the room can overwhelm the patients. So try to remove any unnecessary personnel from the room, and then maintain about 3 feet of distance from the patient, about leg's length, and an angle from the patient, and also having your back against the exit or the door. And there's nothing to gain by being provocative, but rather it is important to engage with the patient by having a one-on-one conversation and speaking in one voice and referring to the patient by their name, and also using meaningful distractors. And be concise, using simple sentences and words in engaging the patient. And also working on really identifying what the patient wants and needs, and also really addressing their feelings by active listening. And many of our patients arrive with delusions that are very off from the reality, but our job isn't to really challenge them, but rather agreeing to disagree. And setting clear limits as early as possible and as often as you can. And also making sure that all of your team members are on the same page about those limits, and making sure that we're all enforcing them as a team. And offering choices. Oftentimes our patients can feel like their rights are taken away when they're confined in the ED. So really empowering them by offering choices and options, and that can also be presented in a form of medications you're offering to the patient when you are controlling their agitation or their anxiety. And this is team sport. So really work on engaging your colleagues after de-escalation and debriefing the case with your colleagues to make sure that you can do this better the next time. And also on top of that, when the timing is right, engaging the patient to debrief with the patient to make sure that you include the patient's voice, and also to prevent future escalating episodes. And as I mentioned, this is team-based approach and team sport. However, there aren't really any standardized approach to a team-based agitation management, unlike the codes that we run for ACLS and ATLS. And there's a study that came out last year, led by one of our speakers, Dr. Wong, that looked at implementing an interprofessional code response team within the ED. And that showed a 7.3 proportionate decrease in restraint rates from pre to post. Again, highlighting the importance of coordinating care when you're responding to an agitated patient. And also, that is a great time to build in a checkpoint where you can think about bias mitigation, as well as providing trauma-informed care, even when you're managing an agitated patient. So this is an algorithm that came out from Boston, and looking at if there is an immediate threat to the patient or staff, yes, you have to consider medications and physical restraints. But if that's not the case, then taking a time to do a bias check. So that includes thinking about what are you perceiving as a threat, and also how are some of the things that we talked about driving that perception of threat, and how can I mitigate that for me and also my team. And also engaging the patient and thinking about how is the patient perceiving the threat in the moment, and how can I help our patient feel safer in this setting. And then lastly, do I feel supported, and do I need to engage other members of the team so that we can all safely take care of the patient. And with that, I'm going to pass it off to Dr. Wilson.
Wow, thank you. So nice to see you all. It's unbelievable to me, standing here now in 2023, that when we were putting this project beta together in 2012, that we'd still be talking about this. So thank you for being here. Thank you for being part of the conversation. I get the pleasure of presenting you the thing that makes people the angriest, and that is, what medication should we use, okay? I'll just say, and I'll reference, hopefully in the next couple of minutes, a lot of research that's been done by the other folks on the panel. I'll just say, in 2012, when beta came out, verbal de-escalation was something that my nurses mocked me for. It's now considered first line, okay? I don't know when we won that war. I think when it showed up on MRAP. I literally almost drove off the road one day. I was listening to a MRAP podcast, and they said, hey, verbal de-escalation is front line, and I almost hit a tree, which I think is great. But this is something that there is still not a lot of great evidence for, and we'll talk a little bit about that as we go through. But before we start, does anyone know what this number means? Anyone? Percentage of my brain cells left after a night of drinking SAEM? No. Number of lectures I'll attend at this conference? No. Anyone? Seriously, anyone? Yes? Oh, close. Yeah, the answer was percentage you can verbally de-escalate. Very close, very close. See me after. We'll get you a drink anyway. This is, according to the Emergency Nurses Association, this is the number of your staff, your nurses, that were physically or verbally abused in the last 7 days at work. I just want to let that sink in for a minute. Your job is hard, their job is harder. But by following a lot of these principles, you'll make both your job and their job a little easier. All right. Here's my first very controversial statement. Please stop saying chemical restraint. That's not my words, that's CMS. If you say you're giving a med to restrain a patient, it's no different than if you physically restrain them. You have to follow all of the same regulations. We don't give meds to restrain patients, we give meds to treat patients. It's a subtle but incredibly important difference. This is the original 2012 psychopharm from Beta. I wish I could tell you there's been a lot of updates in the last 10 years. Martel and Ambrose and Lynn and Dana have tried their hardest. They've done a lot of great work. Unfortunately, they're being hamstrung by a lot of FDA stuff. So when we did a systematic review a couple of years ago to look at it, it did not fundamentally change these conclusions. But let me just tell you the next controversial thing, and that is if everything that you have, if every agitation episode in the ED looks like a nail, you will hit it with the same hammer. Don't do that. You wouldn't consider giving the same broad spectrum antibiotics to everybody with sepsis, so don't do it for agitation. Try to figure out what the agitation is most likely associated with. And sometimes you can't tell. Martel has made this point many times, and he's absolutely right. Sometimes it's difficult to distinguish substance use and psychosis, and a lot of times they're mixed. That's okay if you can't tell. But if you're treating all of your agitated delirium patients, especially if they're elderly, the same way you're treating the 20-something who's ingested too much meth, you are not helping your patients, and you're not helping your department. So the first thing you have to do is you have to figure out the most likely cause. Is it a delirium? Is it intoxication? Is it a known psychiatric disorder and they've just been off their meds? Or can I really not tell? That's the first level. The second level is use oral meds. Now, I know I read the ACEP clinical policy that's being proposed right now. Anybody ACEP members in the room? Okay, one, thank you. That's a second beer for you. Find me afterwards. I have Martel's credit card. We will definitely we'll go out crazy tonight after. Anyway, this is probably not going to be applicable since not a lot of ACEP members, but ACEP is considering a clinical policy on treatment of severe agitation that does not include oral meds. Why? Because the minute people hear severe agitation, they think, hey, can't really give oral meds. That's not true. People who can't take oral meds can't take oral meds, but severity of agitation doesn't seem to correlate very well with that. So consider on the first row here, oral medications. Then if you can't, that's when you hold people down, like Lynn's first picture, and you give them an injection. Oral medications work very quickly. This is 20-year-old data that has shown, this is from Glenn Courier, has shown if you give people 2 milligrams of oral risperidone and oral lorazepam, it works just as well as if you give them 5 milligrams of Haldol and 2 of Ativan. Those lines are overlapping, okay? They work just as well, even though, interestingly, the time to peak plasma concentration is obviously different between the two routes. Clinically, they work similarly. So, I work in the same environments you guys do. My nurses wish we had a crop duster we could fly through the waiting room, right, on a busy Saturday night and just medicate everyone. Don't do that. Treat to the most likely cause of the agitation, and with that, I will turn it over to Dr. Wong. Yes?
So that the first time point on that chart,
Yeah.
the 30-minute mark, I feel like it's a really easy activity to move forward at like the 5 to 10-minute mark. Perhaps, if there's any discrepancy in there.
Sure. So no, they did it this way because that's when they measured. Look, I'll just say this. I'll make another controversial statement since you nicely led with that question. If you have a patient that is so agitated that 5 minutes is going to mean destruction of your ED, your therapeutic options are limited to police, injection, and restraints. That's just not how most of the studies look. Most of the time, we can verbally, and I do this routinely, I will verbally de-escalate the patient that the nurse says we can't do anything with while they are getting medications out of the Pyxis. We give the oral medications, and within 30 minutes, they're already better, right? But no, in the patient you described, your options are extremely limited. And Ambrose will talk about physical restraint of that. Again, we view this as a last resort. He'll talk about some of those reasons, but basically it's bad for patients, and it's bad for providers. Our providers get hurt. So, Ambrose? Yeah, oh, sure.
You know, I think to your point, though, there's probably a middle group here that we haven't quite found the perfect medication for. There's the person where you probably have 10 to 20 minutes. And, you know, this is old data and they're old drugs, I'll be honest. But I think, you know, we need to look at that group, and there's a lot of work still going on there. We do use some old drugs. Sorry, Dr. Wong.
No, it's true. I think unfortunately the answer that you might get from all of us is that there is no perfect drug, and there is no ideal medication that treats that kind of agitation you're talking about, and that's why we need more funding and more research to do it. I think that's the reality. So my name is Ambrose Wong. I'm a health services researcher at Yale. So I'm just picking up a little bit and talking about restraint, really talking about specifically about physical restraint, and just some things to think about clinical pearls and also indications. And then I was just thinking a little bit about your own risk as a clinician and your interactions with the patients as you're applying these physical restraints. So Mike Wilson talked a little bit about this as well when he was talking about his part about pharmacotherapy, but there are some significant medical legal, but also clinical risk to physical restraints. And so as a clinician, you really want to think about physical restraint as a last resort unless you absolutely have to. In reality, when we work in the ED, that's very commonplace that you're stuck in that situation. And there are a lot of situations where physical restraints are inevitable. That's just part of our daily job in acute undifferentiated agitation. So I would just consider that is something we need to get done, but just thinking a little bit about it consciously as you're making that decision about physical restraints. So the definition of restraint is actually pretty broad. It's basically any method that you're holding someone against their will, and it could be arms, legs, a body, or head. And like Mike said, a chemical medication that's given can be considered a chemical equivalent of a restraint. And so when you're thinking about how you document it, but also how you're thinking about using the medication, are you using it therapeutically as a way to de-escalate the patient or to give them a little bit more calmness? Or is this you're doing something because potentially you're doing this punitively or in a way that's to actually restrain them, hold them against their will? And technically non-clinicians, so I should say non-providers, mid-levels or MDs can actually apply physical restraint without our direct consent immediately. But we do have to document that we agree and concur with that within an hour and that we have to do a face-to-face evaluation. So something to think about that as well. Obviously, as clinicians and as physicians, we want to be right there making that decision, but in certain situations that may not be feasible or possible. But just make sure that that documentation has to be within an hour. As you all know, physical restraints come with a lot of risk. And honestly, the studies that are done on these complications of restraint are really old data. But they're kind of terrifying data about the risk of apnea, death, rhabdomyolysis. You read it, it really gives you pause about using restraints. And the other thing that my team wanted to emphasize is the times when us as clinicians are most at risk for physical injuries and assaults are during the restraint period. Obviously, those are the times that it's also most threatening for the patient, but it's also the times that we have most direct contact on the patient and the times where the patient is getting the most aggravated because they're about to get restrained and things get really dicey and you're very close in proximity to the patient. And so those are really the times that we're actually the most risk. So if there's any way to avoid it, that would be really ideal. One thing that our team did a couple of years ago was to actually talk to some of our patients who experienced assault, experienced restraint in the ED to hear a little bit about what their experiences were like. Oftentimes we sort of project their feelings and also their experiences and their response to the restraint at the time they would interact with them. But it's interesting to hear a little bit about how they feel and their experiences after the fact. And these are just a couple of examples. I won't read in detail because of time. But since then, I've worked a lot with individuals who have lived experiences of restraint and being in the ED agitated. And there's a couple of big takeaways that they tell me. Number one, they hear what you're saying even if they're agitated. So the de-escalation pieces that Dana was talking about is really key. Even if they seem like they're not necessarily agreeing with you or they're very agitated, they retain and hear that information, and it actually creates a therapeutic alliance that you may not physically realize as you're interacting with those patients. The second thing to think a little bit about is even as you're restraining them, they want to hear a little bit about why you're doing it. So be at the bedside and explain, this is the step we're going to do, this is what we're doing. Just thinking about if you're doing an intubation or a central line, you're going to go through exactly what you're doing. You tell them I'm about to poke you. And a lot of these patients actually really respect them. They want to hear that. And the third piece is give them a choice. Giving them a little bit of some decision-making within that time they're agitated is actually really powerful therapeutically. So you can say, and like Dana just said, keep it very concise and short. You would either have to sit on the bed and not yell, or we have to do X, Y, Z, whatever the situation might be. And that at least gives them some power in that decision-making process. And so a couple things to think about. These are just ways to consider you using physical restraints. Have we tried any other method at all, and can we use the most least restrictive method? One thing that Dana said that was really great is if your hospital can create some structured protocols around where you might actually make the threshold decision to restrain or not, and have that implemented system-wide so that the clinician at the bedside doesn't have to make that decision alone on their own. And then also remember to remove the restraint as quickly as possible. The techs and the nurses are often doing that for you, but sometimes you forget them on the back of wherever you're working with these patients. So thinking about that as well. And then staff training and coordinated care with your nurses is vital. All right, and finally, Dr. Martel will close us off.
And I'm here to talk a little bit about kind of the next phase, the clearance and disposition of patients. And I was thinking about it as I was kind of preparing this conversation for you, and I first gave a version of a talk on medical clearance, if you will, about 20 years ago. And so I've worked over the years and recently to try and update things, and I'm sad to say in this field, again, there's not much that has changed. There's been writing about it, don't get me wrong, and there's been some authored papers, but there's not a lot of real prospective research here, and it's because it's complicated. But I'd like to start with the point of what is in the name medical clearance. What does it mean to you guys when you write medically clear for psychiatric evaluation on your chart? What does that mean? Don't make me come around and tap you on the shoulder. Scream it out. Like, what do you actually mean when you write that? Okay, you like my statement there. What were you going to say? Okay, anybody else? I saw a hand somewhere over here. So can I ask you, why don't you just write that? It does. I mean, I'll be honest with you. I mean, it takes a long time to actually write what you mean. But we know from all of our documentation in emergency medicine that if you don't write it, it didn't happen. If you don't write it, it doesn't matter what you meant. So I use, if I'm really in a rush, I write the term medically stable. And it's not even as good as saying no acute issues identified on focused assessment. But I want you to start thinking about that phrase because it's really important in my mind. From a patient's perspective, most importantly, because you don't want them winding up in a psychiatric facility and actually having no one address their medical concerns if they arise because you said they were clear, but also from a legal perspective. You know, it's probably worthwhile to document what you did and document what you mean. And practically speaking, when you walk into a room of a patient that you've already been dubbed because the track board says or Epic says, you know, psychiatric decompensation or SMI or psychotic, you have to really make sure that you walk in and decide what's practical to assess and what is really in the patient's best interest to assess. And whether you're going to do it in some fashion, like looking at comorbidities, et cetera. Talked about that. The lowest common denominator. If you look at all the research, first of all, you could literally say this half of the room says that you need to do everything from a TSH to a head CT to an LP on patients who come in needing to go to a psychiatric facility. And this side of the room could find data to say, well, you need to do absolutely nothing but say hello. I think when you really scrutinize the data out there, these are the key points. Actually talk to your patient. See if you can figure out what's going on. 2, do a physical examination. That doesn't mean walk in the door, say hello, and that's your door exam. Like every scribe has their door normal exam that they pop into your notes for you, right? No, actually do a physical examination, and that includes looking at the skin. Because if you look at some of the data, things that you'll miss are like cutaneous infectious processes causing, delirium. And then vital signs. Really, if you do nothing else on a psychiatric patient, aside from these 2 other things, make sure that they actually have real vital signs. Don't accept 120/80 respiratory rate of, 16, SATs of 99% or whatever. Actually get real vital signs. Because tachycardia is probably one of the most common things that you'll find that should draw you to look further. Fever is the other thing that you don't want to miss. So an axillary temperature on a psychiatric patient or one of those laser thermometer things across their forehead, I can check your temperature right with this thing. Well, I guess I could go really fast through my slides, but I think there is a laser on this. So those are the lowest common denominators. And the medical etiologies, we could come up with a differential diagnosis for delirium or agitation, et cetera. But I think when it's all said and done, you actually have to go through that in your head. I certainly would not suggest that you, again, need to do a head CT on everybody. And please don't send a TSH on every possibly psychiatric patient in the emergency department. You can pick that up as an emergency clinician 99% of the time just walking into the room. If someone potentially has myxedema coma as a reason why they're in the ED with what could be a psychiatric issue or whether they're, have thyroid storm. And again, just be detailed. Long story short, though, I think that if you're focused and you have a rationale, it's important kind of looking for these etiologies. But when it's all said and done, I would be crazy not to say that I realize that many of you work in shops where in order for a patient to be accepted at a facility, they have to have a protocol. And it's literally you check the boxes, including LFTs, which drives me crazy. If you work in a facility where you have the ability to actually talk with your accepting clinicians, it's actually really valuable. I work in a shop where we have our emergency psychiatric facility just across the hall. And they think it's crazy when I actually walk through the doors, because my badges work over there. They should take it away from me, but very few emergency docs actually know that you can go over there. I walk over there and I actually talk with them. And so when they say, well, I think the patient has alcohol withdrawal, or whatever it is, reasonable folks actually have reasonable conversations. You just have to try. And so I look at it as advocating for the patient. There's no reason to subject them to additional testing. Even just a simple needle stick for someone in psychiatric crisis can be a big deal. We were just talking about that. Mike talks about verbal de-escalation finally being accepted. I remember one of the nurses would look at me and say, "You have the best verbal judo of any doc I know." We've come a long way since 1990s. So, and again, I think disposition is a whole nother topic on its own. But I want to really encourage you to be patient-centered, really focus on the basic things, vital signs and history, and actually examining the patient, and then kind of looking towards the next step and really advocating. So, all right, with that, I leave you with some puzzle pieces for Dr. Roppolo to put together.
How's everybody doing? Are we still with us? So thank you for your attention. I don't see anybody sleeping. So we just wanted to take a moment and bring this all together. And so this is kind of a figure or diagram, flow chart, if you will, that we put together in a review paper that we wrote a few years ago. And just want to take you through our approach. So let's just say we have a mildly agitated patient, which we see frequently, and a lot of these patients respond to de-escalation. For all levels of agitation, just remember de-escalation. And if you can't remember all the domains that Dana talked about, just think about grandma, or think about somebody you really respect, and get down to their level and just try to bring them down, try to partner with them, show them that you care, and make it simple, and just kind of go over and over and just reinforce those words. But sometimes these patients need medication. All right, sometimes you can give, my favorite drug in the emergency department now is Zyprexa, oral Zyprexa, 5 to 10 milligrams ODT, and then sometimes, giving them a sandwich or giving them a blanket. A lot of our nurses will say, "Why are you giving him a sandwich? He's just gonna come back to the emergency department." And I'll look at the nurse and I'll say, there's nothing that will keep this patient from coming back to the emergency department, and if anything, it's gonna just kind of reinforce that you care and hopefully help de-escalate them. So most mild patients don't need anything more than that, but sometimes they escalate to a severe level of agitation. In a very rare situation, you might be able to de-escalate a severely agitated patient. I mean, I think, many people, they get just irate and upset for different reasons, and it's a variety of reasons. So don't not try to de-escalate a severely agitated patient, but you're gonna do it really briefly, and in seconds, I think you can see if it's gonna work or not. So for the severely agitated patient, this is your patient that is violent. He's on the verge of hitting somebody. He's throwing things. He's gonna hurt himself. This is a person that you've tried everything conservatively, compassionately, and unfortunately, you're gonna end up having to give him some forced medication and restrain him. What we usually do, if we have a patient that we think is going to be potentially a danger to himself in a significant way or to us, we call the police. There's a button that we push at Parkland. 5 police immediately come within seconds. And if anything, they can help us reinforce our de-escalation. If having all those people, and everybody just treat them individually, if you sense that their presence is making the patient more agitated, I'll just go in with 1 police officer, because we gotta always remember to be safe, and kick everybody else out of the room if it's safe to do so. But sometimes the patient does need to be physically restrained. And so the doctors will go and They will put in orders in the computer, and then the police will go around the patient if it is determined that this person does indeed need to be physically restrained. And then the nurse goes and gets the medications. And she's actually literally just standing there at the bedside with a syringe, and they're usually for severely agitated patients, always IM injections. Sometimes we'll just inject through the jeans or whatever we need to do. And she'll just stand there and wait until the police tell her it is safe to give the medication. Okay? The nurses, the techs, people who are not trained to do so shouldn't be involved in the physical restraint of the patient. And so then when it's safe to do so, they give the medication. The doctors, I know it's important to do a physical examination, but in a severely agitated patient, you are keeping your distance until it is safe to do so. And then once they're sedated, all the monitors are placed on the patient, capnometry, pulse oximetry, cardiac monitor, and when the patient is calm, you want to, by the way, when you physically restrain somebody, you want to try to keep them prone, head of the bed elevated. Sometimes you can kind of put one arm down, one arm up, those kind of things, but you shouldn't keep them prone, and you should be, as a team leader, making sure that their airway is protected, nobody's pushing on their chest, those kind of things. So safety, not just for you, but for the patient is very, very important. So anyway, and then, depending on the situation, you can do your medical workup if you need to medically stabilize the patient, or maybe this person's just intoxicated and he just needs to calm down, or has a psychiatric reason and needs to give him medication and because he was off his meds or whatever. But any questions on this? Yes. Yes. I'm sorry. I was speaking fast. So, yeah, not prone. If you have to restrain them, and the easiest way to restrain them is in a prone position, that should be very transitory, very temporary, and then you give them the medication, then you turn them supine. Thank you for correcting me. Any other questions? Sorry about that. Yes, ma'am. Yes. 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 Definitely, and I'm glad you brought that up. Sometimes we could have different approaches, but you have to be on the same page with this. And at Parkland, we've been able to work with our police, so we are on the same page. We communicate when we need them. They're always around to support us, but we are in charge of kind of the whole management of the patient, including initiating the de-escalation. But sometimes, we have them come in and step in as like backup or continue the de-escalation. So everybody is individual, but it is definitely important because we have different approaches, that we're on the same page and we work as a team, and everybody is equally important and has their role, but it's just, based on your own unique system to make sure that you guys know that ahead of time, so when you have these scenarios, you guys do your best to manage the patient. But I'm glad you brought that up. Thank you. Yeah.
Had a really articulate stimulation where they included, I thought it was really great, talk about stimulation.
I'm so glad you brought that up, because that's a good segue into what he's going to talk about. He's going to talk a little bit. No, that's okay. I'm so glad you brought that up. Anybody else? Yes.
Thank you for bringing the point up, because not all security is created equal. I've been incredibly lucky to work with an amazing security team that's been very patient-centered from the beginning, and training has emphasized that. It always makes me leery when institutions use police. Now, that's not inherently negative, but if you always look at nails, you're always going to respond with a hammer. And I think there's a real incredible distinction here, because we deal with patients. We don't deal with prisoners. So I think it's imperative, if you work with a law enforcement agency, you need to really take the lead in how they interact with your patient.
Thank you.
Thank you. We know this is the end of the day, so thanks for sticking with us. We're going to try to wrap up on time and then open up a Q&A, because I'm sure you guys have also have your personal experiences and expertise as well. So just moving on to a couple things. Thank you for bringing that up about our simulations. And actually, Marc made a really good point about we call them protective services at Yale, but our security officers. there is a range of their own expertise and baggage and backgrounds. I have been very fortunate to find a couple of local champions who are very invested in being patient-centered and want to work with us. And so there was one lieutenant who basically handpicks their officers to work with the ED with us. And we have started doing training together as a team and started looking into sort of what the conversations are like between officers and clinical staff, not just during agitation moments, but really just working day to day with each other. And part of it is that we just speak different types of language, both in terms of clinical management, but in terms of what they think about agitation. And a lot of them do have some sort of military or police or some sort of background that's really around law enforcement. And they think about these individuals differently than we do. And I understand they've been in the field and they have their experiences, and I'm sure they see a lot of things that we don't see in the clinical environment. But as a result, they have a lens that's very different from ours. And a lot of us have never had any experience with weapons. We don't deal with patients or individuals that are assaultive on a daily basis. We have no formal training in personal defense, other than folks who might just do that, leisurely, or because you have some sort of MMA background. Thank you for those who do that, because you guys saved me when you work clinically. But working as a team is really key. And so as we're training together, what we're trying to do is bring those Venn diagrams together. And so the circle on the right is really thinking about these individuals that are agitated as potential security threats and folks that may have an intent for malice. And the reality is that that does happen in the ED, right? We see that, and people do potentially become assaultive because they are dangerous and they're malicious. But 99% of the time, maybe not 99, but the majority of the time, they're patients that have a behavioral emergency, they have clinical need, they're here because they're brought in against their will, they're either in a psychiatric crisis or something else. And so we want to respond and move that barometer more towards the left, and knowing that there is an overlap, and when we overlap, we have to work together as a team. So just hoping to start that dialogue with your security staff wherever you work. I'm thinking about doing that training together. All right, Dr. Wilson, will you summarize for us?
All right. Thank you all for sticking through the entire presentation. This is my last best chance to misquote all of these fabulously talented panelists that have done a lot of great work, and I've actually collaborated with all of them on different papers. So I'll just say from starting out at the top, from Lynn, you heard that behavioral emergencies, kind of like a good code, in fact, it was actually Dana who showed something from ACLS, but kind of like a good cardiac arrest, require a team approach. I'm biased because I was part of the original beta project, but I think those principles start with many of the principles articulated in that paper. Lynn wrote a very nice paper in 2020, JCEP Open, look for Roppolo et al., that summarizes pretty much the last 45 minutes that you heard. Ambrose wrote a wonderful paper, is 2021, in the height of the COVID pandemic, that summarizes a lot of this and the modifications we had to make during that time. From Dana, you heard about the importance of verbal de-escalation, and she talked about the principles. I'll just say it's based on science. Gaines, 2017, Psych Services did a very nice systematic review backed by AHRQ. Verbal de-escalation works. You can check out that paper. And also, if you're interested in quality improvement work, Dana wrote last year in Annals of Emergency Medicine the definitive work on quality improvement outcomes for behavioral emergencies in the ED. Then you got to hear from me, and I said a bunch of stuff about meds. I still believe meds with verbal de-escalation are better than either alone. From Ambrose, you got to hear about physical restraints. He took a lot of the older data done outside the ED and did a really nice qualitative study that shows we harm patients psychologically when we restrain them. Yes, you may have to do it, but please do it as a last resort. Also, most of your staff injuries are associated with restraint procedures. We harm our patients, I'll say it again, and we harm our staff when we have to physically restrain someone. Let's set up the system so that we can make that as infrequent as possible. Finally, from Dr. Martel, who's done really most of the definitive clinical trials in this regard in terms of managing agitation and behavioral emergencies, you heard about medical screening. He's absolutely right. A lot written about this. We did a systematic review ourselves. There were 60-some articles. One of them was moderate quality evidence. The rest, poor. So you're going to have fights, as he mentioned, with your psychiatrist. Make sure you get them on board. There are medical screening tools. None have been extensively validated. He mentioned that as well. Again, it takes a team approach. You're not going to do it at 3 a.m. on a Saturday morning. You're going to have to do it at a meeting during the week where you get your services to agree. And with that, we will be happy to take questions. And since we're over time, please don't feel bad if you have to slip out. Yes?
Thank you for the presentation. I read that initial 2012 Pharmacotherapy paper and a little bit understand you're all here.
Oh, well, thank you. Thank you. You're very kind. Very kind.
Do you guys have goals of what are you working on next? Are there certain projects in the works right now? What's next on the docket?
So the question is, what is next? And I could summarize really all of the incredible stuff that this panel's doing, but instead, I'm going to turn it over to the guy who's doing some really exciting stuff. Ambrose, do you mind can I put you on the spot to do a 30 seconds of what you're doing with your life?
Yeah, well, Lynn mentioned a little bit about workplace violence. I think the one thing that we all think about, and hopefully the panel kind of expressed this, is the thought about bringing workplace violence and workplace assault together as a similar topic or the same identical topic as agitation management, because really those are one and the same. And so I think bringing those fields together in ways through research and scholarship would be the most key. Lynn was whispering to me to try to bring assault to zero and to think about the staff and the patient safety really as one and the same thing. I think that's really hopefully where we're moving on next, rather than addressing them separately. Because even thinking about ASAP, for example, they have strong guidelines and policies around workplace violence, which is really important. None of us want to get hurt. But really, that's not necessarily happening in isolation from what's actually the cause of it, which is agitation. So I think that's one thing that we want to think about. The other thing that Dana and I also have talked a little bit about is really bias and equity. I think it's going to be remiss of us to not think about the patients that are most commonly agitated are the ones that have experienced homelessness or housing insecurity. Minorities happen a lot, folks that are in the low socioeconomic status. So I think that's something that we think about as we're restraining and sedating these folks. So that's something to be really mindful of, as Dana mentioned, is what is your own perspective on this particular patient when you're managing them, and are your own personal biases at play when you're taking care of these people? So things to think about.
So I'll just say that was a fabulous answer, and also completely did not answer the question, because you in particular are working on some amazing stuff. So Ambrose has 2 NIH grants at the moment working on problems of agitation. Dana continues to do prospective research on DEI. Marc and Lynn are both teaching the next generation of residents. Both have been very invested in MedEd. This panel has been extraordinarily active and will continue to be. I personally have taken on a little more advocacy role. I am now chair of the Coalition on Psych Emergencies, and I was just in DC 2 weeks ago to advocate for better laws against workplace violence. So we are, as a group, continuing to work on this problem. All right, sorry, we'll do one more and then we'll let you slip out. Yes, sir.
A quick question about pharmacotherapy, specifically in the sedation and severely agitated patient. I noticed on the slide that there was sort of a recommendation of either specifically lorazepam or monotherapy antipsychotics. I'd be curious to hear from your crew commentary on the common practice of co-administration of antihistamine or benzodiazepine.
So the question was about co-administration of antipsychotic and benzodiazepine, and now you're about to watch this great panel that gets along really well suddenly go at it, I think. Okay, but since I have the microphone, I'll give you my opinion first. I think it's a terrible idea. Just like when you're getting ready to intubate someone, the more drugs you have to mix into the cocktail, the greater potential for error, the greater potential for side effects, et cetera. You do not need to add a benzo reflexively onto every antipsychotic. Cochrane-level evidence that has looked at this has said that benzo does not add anything to your antipsychotic and quite possibly exposes the patient to more adverse events. If you start mixing on a benzo with a second-generation antipsychotic, Lynn likes olanzapine, you do run the risk, again, of higher side effects. We showed this in our research, especially if the patient is alcohol intoxicated. But for the other side, oh, yeah.
My impression is that has it decreased time to effective onset? Go ahead. You guys obviously.
Oh, sure. Well, so that was the Battaglia 1997 argument, okay? But that paper has really only sort of a moderate class of evidence. Again, Cochrane level of evidence has not found that. Mark, go ahead, give me the other.
Well, and we recently reviewed the combination of, using Benadryl. There's really no added benefit. I mean, we always worry about akesthetic or dystonic reactions, and practically speaking, I'm now in the camp of you can treat it. Mike says that I'll be kind of the antithesis to his point, but I think in the grand scheme of things, there's a lot of data out there. You just wanted to see if I would fight with you. Data that I kind of presented, 2 decades ago showed that if you want monotherapy, Versed is actually your choice for quick onset medication. It really is a focused treatment, and it's, again, kind of approaching that class of acute undifferentiated agitation. I don't think you buy anything combining it, and I actually, I encourage you, if you are actually ASEP members, to look at the ASEP policy out there, because it has the potential to influence practice, and I'm not sure I can confidently say I don't stand behind what's written out there. I have a lot of concerns. I kind of answered your question, but I think, whether we look at the beta kind of pharma guideline or you kind of look at your clinical practice, you can usually have a pretty decent sense of what's going to work in the situation, what's going to be beneficial, what's going to be most patient-centered. Sometimes you have to, kind of make your best guess or do a combination, but have a good reason behind it. Treat your patient.
So we're going to try really hard next panel to find something else to disagree on. Did you have one last comment before we close? Okay.
Yeah, just so at Parkland, because we have so many people, we have 26 residents, over 100 faculty, and so we try to put everybody on the same page. So we created a agitation order set on Epic to just basically provide guidelines. And just for the severely agitated patient, sometimes it depends. We divided it into patients that are psychotic and then just undifferentiated. If they are psychotic, we always include an antipsychotic. So it's either Zyprexa with no benzo because it is very sedating, and your pharmacist will come up to you and argue. There's right here, 2 of them. And so it's a Zyprexa 10 milligrams IM, or Haldol and Ativan, or Haldol and Benadryl, but never the 3 of them. The psychiatrists frequently want to give the B52. Hopefully we could erase that from practice, because all it does literally is prolong the ED stay. And also they were talking about just the EPS side effects and all that stuff. It's very low. So I always like to give Haldol with something, either Benadryl or Ativan, if that makes sense. And then also for the undifferentiated patient, just depending on the situation, but if they're severely agitated, we'll frequently give just 10 milligrams of Versed IM. From a study that you did, said that it was kind of the most rapid control of their agitation.
But associated with most people with need for repeat sedation.
Yeah.
So I'm just going to tell you, in my opinion, the reason why the combos exist is because there is no perfect single agent. So everybody over the years has tried to create something. You take Haldol, a really slow but potent sedative, and you add Ativan to it, so it works faster. I mean, that's kind of the rationale where this came from. Whether it's true or not is irrelevant, but that's what the thought was 30 years ago, 40 years ago, before my time. A lot of those combinations just don't make sense. And the point is you're going to see discrepancies here, but there's a lot of good data that says one drug is better than any combination. So, and I agree with Mike, even though
I know I know it's. Guys, we have now kept you way past the time. Thank you so much. Let me just thank all of our amazing panelists. Thank you all for coming, and please grab us for questions.